As you have seen on the board, my discussion today is the clinical anatomy of the heart. You all know that the major functions of the heart, is nothing but pumping of blood, to each and every other organs or system of the body. So the clinical conditions or diseases that affect the heart are either congenital diseases or acquired diseases. When you hear this word acquired, we are talking about the diseases or the clinical conditions that affect the heart after somebody is born. But when we talk about the congenital diseases, we are talking about the diseases of the heart that are born with that person. So if somebody is born with diseases of the heart, these are the congenital heart diseases. After somebody is born, the heart, if it is normal, and later on he or she develops diseases on the heart, these are what we call acquired heart diseases or condition. Part of the congenital conditions or diseases that affect the heart are what we call atrial-septal defect. You can remember that during embryonic development, the heart develops a septum between the two atria. That means between the right atrium and the left atrium. So there is a septum. This septum, is what we call the septum inside here is what we call the interatrial septum. That means septum between the right atrium and the left atrium. Unfortunately, I was not able to show it on this diagram because I wanted to show the arc of the aorta and the pulmonary trunk. So the septum should be just behind these two great vessels. So that atrial septum may likely have a defect because you know that during embryology, there is a gap between the septum. That means there is a communication between the right ventricle, right atrium, and the left atrium through what we call the foramen ovale or foramen ovale. So if that hole or that foramen refuses to close, that is what we call atrial septal defect. So there will be still communication between the right atrium and the left atrium. So that means deoxygenated blood in the right atrium will be mixing with the oxygenated blood from the left atrium. But what is going on is that since the blood in the left atrium is oxygenated and it has a higher pressure than that of the blood in the right atrium, so that means the blood will be coming from the left atrium into the right atrium, so that the mixing will be inside the right atrium rather than inside the left atrium because of this high or pressure differences. So the oxygenated blood will be mixing with the deoxygenated blood in the right atrium. So the blood that is going into the right ventricle is a mixture of both deoxygenated blood and oxygenated blood coming from the left atrium. That is what we call ASD. And mostly patients with this kind of diseases, they don't have cyanosis because it is the oxygenated that is mixing with the deoxygenated, because blood from the right ventricle is going straight into the lungs. You get it? Another congenital anomaly is what we call ventricular septal defect, and that is what we call VSD. You all know that during embryology, the ventricular septum is made up of two types. We have what we call membranous type of septum, which is this one in blue, and then we have the muscular septum, that is the one in green. So we have two types of septae developing to demarcate between the right ventricle and the left ventricle. And so this membranous septum at times, it tends to have a defect on it, or the muscular part may also tend to have a defect on it. So that means the defect can be either here or can be here on the muscular septum. So anywhere where you have this gap or defect along this either membranous or the muscular, that is what we call ventricular septal defect. And so by so doing, blood will also be mixing between the oxygenated and the deoxygenated blood. So blood will also be coming from the left ventricle into the right ventricle. And if the defect is very large, the blood, the oxygenated blood from the right ventricle may get its way into the left ventricle if the defect is large. So there may likely be cyanosis, because the oxygenated blood, after it mixes with the oxygenated blood from the left ventricle, it is directly taken through the aorta and into different part of the body. And so one may likely have this cyanotic, appearance. The person is going to be looking blue on the body. So that is the ventricular septal defect. And so the other, kind of anomaly that somebody may have is what we call tetralogy of Fallot. Tetralogy of Fallot, tetralogy of Fallot is, a 4-in-1 condition in which, you have what you call right ventricular hypertrophy. That means the right ventricle is going to become hypertrophied. That is one of the presentation or one of the signs one will see as part of the tetralogy of Fallot, because there are 4 significant, conditions associated with tetralogy. That is why it's called tetra. Tetra means 4. So you have right ventricular hypertrophy. So because in normal life, left ventricle is thicker than the right ventricle. Reason because the left ventricle pumps blood against high resistance to the great vessels and smaller arteries in the body. And so by so doing, because of this, the left ventricle is a little bit thicker. The muscle there, the wall there is thicker than that of the wall of the right ventricle. And so, but in the tetralogy of Fallot, which is a congenital heart disease, the right ventricle is hypertrophied. We will see the reason why the right ventricle is hypertrophied after I finish telling the other, condition associated with tetralogy of Fallot. So the second condition is what we call pulmonary trunk stenosis. So that's what we call pulmonary trunk stenosis. So this pulmonary trunk that divides into right pulmonary artery and the left pulmonary artery, this pulmonary trunk now gets stenosed. That means it gets narrowed. So since this right ventricle is now going to pump blood against a narrow opening, so that means it has an extra work to do. So once that extra work, is being applied on this right ventricle, because of the narrowing of this pulmonary trunk or pulmonary trunk itself, so the ventricle will now tend to develop muscles more than it was before. And that is why you have this right ventricular hypertrophy, because of the pulmonary trunk stenosis. This is the second condition. The third one is what we call overriding aorta. We have overriding aorta. So what do we mean by overriding aorta? You see, the aorta opens up into the left ventricle, because as soon as the heart contracts, it pumps blood directly into the opening of the aorta to distribute the blood into different parts of the body. So when we say the aorta is overridden, that means instead of the aorta to open into the left ventricle, it opens into between the left ventricle and the right ventricle. So that means deoxygenated blood from the right ventricle can also gain access into the overriding aorta. That means the aorta is going to open, the part of the aorta is going to open here into the right atrium, into the right ventricle, and also into the left ventricle. So that blood is being, taken both from the right ventricle and from the left ventricle. So there is a mixture of both the oxygenated and oxygenated blood. So that is the third condition. That means we have overriding aorta. Aorta, instead of opening into the left ventricle, it now opens in between the junction between the left ventricle and the right ventricle. So there will be a mixture of both oxygenated and deoxygenated blood. The last part of the tetralogy is what we call VSD. That is the ventricular septal defect. So this ventricular septal defect is mostly found along the muscular part of the septum, the interventricular septum. So that means there will be blood, moving, depending on the size of the VSD. So the fourth one is ventricular septal defect. So we have 4 conditions. Right ventricular hypertrophy as a result of the pulmonary stenosis, which is narrowing of the pulmonary trunk. And then we have overriding aorta opening in between the right ventricle and the left ventricle. And then we have the ventricular septal defect. So this is one of the cyanotic heart diseases in which children are born with. When you go to the clinical side, you will see some small babies born with this kind of condition. The other condition, which is also congenital, is what we call dextrocardia. Dextrocardia, you all know that the heart, major part of the heart is located in the left part of the thorax, but some part of it is located on the right side. So when you divide the heart into 3 parts, that means 3/3, first, second, and third thirds. So the right 1/3 of the heart is in the right part of the thorax. The remaining 2/3 of the heart is located in the left part of the thorax. So that is the normal in each and every one of us here. But unfortunately, in certain individuals, the heart is found on the right. Major part of the heart is found in the right part of the thorax because the heart rotates during embryonic period, so it rotates to the heart, to the right part of the thorax. So instead of you to feel the heartbeat on the left part of the chest, you feel the heartbeat on the right part of the chest. And so other, associated condition with this dextrocardia is associated rotation of the gastrointestinal tract. You all know that appendix is found on the right iliac fossa. But if somebody has dextrocardia, the appendix that is normally found on the right iliac fossa is also going to be found on the left iliac fossa. So there is a reverse. So that is, this dextrocardia is just like bringing about the reversal of the normal positions of our organs in the body. You get my point? So we have the apex bit on the right, we have the appendix also located on the left instead of the right side. And that is what we call dextrocardia. So there is just, interchanging of the normal positions of our some important organs. There's also what we call patent ductus arteriosus. During intrauterine life, there is a communication between the pulmonary trunk and the aorta, so that by the time blood comes from because during intrauterine life, the lungs are not fully developed. So the oxygenated blood that is coming from the mother going into the heart of the developing embryo, since the lungs are not fully developed that time, as the blood now reaches the right ventricle, it passes through the pulmonary trunk, and from the pulmonary trunk, instead of it to go into the right and the left lung, since the lungs are not developed, so the blood now passes through this ductus arteriosus, and then it goes into this arc of the aorta, and then it goes into the different branches of the part of the body. So immediately after birth, this ductus arteriosus tend to close down, because by that time the lungs are open. Because immediately a baby is born, the first cry the baby does, that is what opens up the lungs of that baby. So immediately the lungs open up. The cry, allows the baby to inhale oxygen from the surrounding. And so that oxygen will now go into the lungs, and then the lungs will start functioning. And that is why if a baby is born and it has not cried, it's a problem. You have to beat the buttocks, beat the back for the baby to cry, because that cry is very, very important for the lungs to open up, and then he now takes in the first sip of oxygen in his own or her own body. So immediately the oxygen enters into the lungs, this ductus arteriosus begins to narrow down, and then it continues to narrow down until the first months of life after birth. So it is going to be completely closed. But there may be a condition when this ductus arteriosus doesn't close. You get my point? So it remains patent. So that means deoxygenated blood from the right ventricle, as it is being pumped into the pulmonary trunk, get distributed into the right lung and the left lung. Some portion of it will be mixed with the arc of the aorta, and then it gets distributed into different parts of the body. But then it all depends on the size of the ductus arteriosus. If the amount of blood reaching the aorta there is small, there may not be sign of cyanosis, blue coloration of the body. But if it is very large, the amount of blood going into the arch of the aorta is very much, so there may likely be some sign of cyanosis, because deoxygenated blood looks bluish, in real life. So some people who are light in complexion, when there is cyanosis, you will see that the skin color turns blue or blue-like color. That is what we call cyanosis. Cyanosis just from, blue color, cyanosis. That is what it means. So again, you may also have another condition known as coarctation of the aorta. Coarctation of the aorta is the narrowing down of the aorta itself. For example, here now you see that the diameter of this aorta here is not the same diameter here. That means some portion of it has been narrowed. And so this is also congenital. So babies are born with this coarctation of the aorta. And so the amount of blood going into the distal part of what the coarctation is very small. You get my point? So some part of the body distal to the area of coarctation is going to be deficient of the enough blood supply. Are you clear? So that is it. So it can also happen, or the babies can also be born with this coarctation of the aorta, and somebody may have what we call myocardial infarction. When you hear this word infarction, it means part of the muscles of the heart is being devoid of blood supply. You all know that the heart is being supplied by arteries, what we call coronary arteries. So we have coronary arteries. These coronary arteries, they supply different part of the heart. Are you clear? So once any of these coronary arteries supplying the heart get blocked, as a result of certain conditions or whatever, there are so many predisposing factors to development of the myocardial infarction, which I don't want to, confuse you now, because you are still, at your infant state. So I can say that once any of these arteries, the coronary arteries, is being blocked by any of the predisposing factors, something like all this hypertension, diabetes mellitus, all of these are the common ones that you people should know in our environment. So certain chemicals, so the arteries tend to narrow down or tend to get blocked. So once it is blocked, the area that is being supplied by that coronary artery is going to be devoid of, blood supply. And so one will be feeling pain in his own chest. And that is what we call myocardial infarction. If the infarction, is sustained for a long time, this is one of the major causes of the sudden death in our locality. You will be with your own friend now. Within the next few minutes, they will tell you that person is dead, while you know that that person is very healthy and now is dead. And so myocardial infarction is one of the common causes of sudden death, not only in African countries, but even in the developed world, like US, UK, and so on and so forth. So we should just note that myocardial infarction is, a condition in which the coronary arteries get blocked, and so the area being supplied by that artery gets devoid of, the blood supply, and so one is going to experience very excruciating pain in the chest, and so the pain can also be transferred or referred to the medial side of the arm because of, share of the nerve supply around that side. So now we know that what is myocardial infarction. We also have what we call valvular stenosis. You know that we have valves between the atrium and the ventricles. That means between the right atrium and the right ventricle, we have what we call tricuspid valves. Between the left atrium and the left ventricle, we have bicuspid valves. These valves can get stenosed. So also the pulmonary trunk has valves in it, and also the aorta also has valves in it. These valves, any of them, either the tricuspid, the bicuspid, the valves of the aorta and that of the pulmonary trunk, any of this can get stenosed. That means it gets narrowed, so that the amount of blood going from that, compartment, either the right or the left, is going to be limited. So that one can cause also reduction in the blood supply. If it is from this pulmonary trunk, the blood that is going from the right ventricle into the pulmonary trunk is going to be limited because this valve of the pulmonary trunk is stenosed. If it is this one, the tricuspid valve that is stenosed, the blood coming from the superior vena cava into the right atrium is going to be low, the one that is going into the right ventricle. The same thing on this left chamber of the heart. That is valvular stenosis. Again, you may have what we call aortic aneurysm. When you hear this word aneurysm, we're talking about the dilatation of the aorta. So the aorta here, this one, if the diameter here maybe is 3 centimeter. So in aneurysm of the aorta, this diameter may increase. So it may balloon out. Aorta, so there will be ballooning of the aorta. This is what we call aneurysm of the aorta. That means there is dilatation of the aorta itself. So and this aorta, once it dilates, it may burst out just like a balloon. And so once the aneurysmic aorta bursts out, there will be bleeding, excessive bleeding at the area where the aneurysm is. So you see that aneurysm is very dangerous. So that is that. You may also have what we call pericarditis. You know that the heart is completely enclosed by the pericardial membrane. And the pericardial membrane, there is one that is adherent to the substance of the heart. That is what we call visceral pericardium. There is one that is just enclosing the heart. That is what we call the parietal pericardium. In between the two, we have what we call pericardial fluid, so that the heart will now contract without any friction because of that pericardial fluid. So there will be a time when this pericardial membrane, either the one around the heart, that is the visceral, or the parietal, any one of them can get inflamed from diseases. For example, septicemia, that means somebody who has typhoid fever, and so the microorganism can now inflame other organs like the heart or the pericardial membrane itself. So once the pericardium is being inflamed or infected by this bacteria, that is what we call pericarditis, inflammation of the pericardial membrane. And the pericardial membrane, if it is inflamed, the fluid that it secretes in between the viscera and the parietal, the fluid is going to be excessive. And so the amount of fluid is going to increase, and that is what we call pericardial effusion, because the fluid is going to be much greater than the amount being secreted because of this inflammatory process of the pericardium. So by the time the fluid in between the pericardial cavity is, so the heart will be contracting inside pool of fluid, just like the heart would be swimming inside water like that. And so the heart will just find it difficult because the cavity is going to be tensed because of this accumulation of the pericardial fluid, that is effusion. And so the contraction of heart is going to be definitely, affected. You get it? And so that is pericardial effusion. And so if heart had these problems, for you to be able to investigate the heart problems, there are important investigations that one can do to delineate the kind of disease or condition that the heart has. Something like the electrocardiography. That is what we call ECG. That electrocardiography is going to give you the normal reading of your heart function or heart systolic and diastolic movements. So in case there is any abnormality with regard to the systolic and diastolic of the heart, that ECG is going to indicate. And so you can do further investigations, what we call echocardiography. That echocardiography is just like you use this ultrasound machine, while you are going to put the probe on the heart, and then that will tell you whether there is VSD, whether there is ASD, whether the heart contractions are normal or not, or any abnormal heart sound, what we call murmurs in medicine. So it may indicate, the kind of condition that one has. So these are the two important, and you can also do X-ray. X-ray too can also indicate certain condition of the heart. For example, when the heart is enlarged, what we call cardiomegally. So cardiomegally is the heart enlargement as a result of, enlargement of the walls of the heart, like the left ventricle or the right ventricle in any condition. So when the heart enlarges, the X-ray can show you that the heart is enlarged, whereby when you do that cardio-thoracic ratio that I discussed with you in the other video, that will indicate whether the heart is enlarged or not. So X-ray can show you that. So if you want to treat certain heart diseases, that's what we call cardiac bypass surgery. So in case that, for example, if this is one of the arteries supplying the heart, if this is one of the arteries supplying the heart, so maybe this area is blocked. So this side where the blood is coming is blocked. So this side will all be devoid of blood supply because this side is being blocked by this artery. Are you clear? So for you to be able to treat, you can do what we call cardiac bypass surgery. So you can get some veins in the leg, like the saphenous vein. You can harvest it in the leg, and then you can come and plant it. So you can join this saphenous vein, you tie it with the aorta there, and then you can come and link it to the area distal to the obstruction. So that blood will be coming from this aorta, it can come here, and then bypass this area of, are you clear, of the block? And so the blood will be coming here and supply this area. That is what we call cardiac bypass. Or at times, you may use what we call thrombolytic chemicals or enzymes. That's what we call thrombokinase. This thrombokinase is one of the enzymes that degrades this thrombus, because if the artery is blocked, it is as a result of the thrombus, what we call blood clot. So it will now block this artery, and so this thrombokinase will now come and lyse, it will chop up this block so that blood will just continue going there. Are you clear? Or at times, you may do what we call cardiac angioplasty. Angioplasty is like you now use an angioplast, an inflatable balloon. You put it through veins, and then, until it reaches the heart, under the guide of certain, machines, the ultrasound machine and whatever. So until it reaches this place. Once it reaches the area of blockage, the balloon Once you inflate it, it will now dilate this area of blockage so that blood will be pushing into the area distal to the blockage. Are you clear? So these are some of the things that I think you people should note about the clinical anatomy of the heart.